Chiara did her PhD, in fact, on the aorta study at KU Leuven in Belgium. She subsequently worked in Rome, but was appointed a year or so ago now, working in gynae-oncology diagnostics as a consultant at Imperial College in London. And we also have Jen Barcroft, who is writing her PhD on mainly quite a lot around machine learning, radiomics, and ovarian masses. So both of them have a lot of experience, and I know they've got some nice cases to run through. Do fire in your questions to put to them, and I'm going to hand over to Jen and Chiara to discuss some cases. Thanks very much, both of you.
It's a pleasure to be together with this session. We are going to discuss some case of annexal lesions seen on ultrasound, how to describe them, and how to classify them using the IOTA two-step strategy. I'm Miss Chiara Landolfo. I'm a consultant gynecologist, and I'm here together with Dr. Jen Barcroft, our clinical research fellow. And she's going to start with the first cases.
So the first case is a 50-year-old premenopausal lady who was multiparous, and she presented with some intermittent pain, which was the reason for the ultrasound. Previous surgical history included a cholecystectomy. So this is the still image of the lesion. And you can see on the left-hand side, we've got a demonstration of vascularity or absence of vascularity in this case. And the right image is showing you just the size, just because as we know, when we're thinking about the two-step strategy, it does rely on knowing the size of the mass in order to know whether it's applicable. So you'd agree this is a unilocular cystic structure. There are regular cyst walls, anechoic content, no internal vascularity. And the maximum size there is just around 6 centimeters. So as we've already described, this is a unilocular mass, maximum size for 62 millimeters, no solid component, one locule, no acoustic shadows. You can see here there's some shadows, but that's coming off the bowel, and no pupillary projections, and a color score of 1, meaning absence of any internal vascularity, and no ascites. So thinking about the two-step strategy, and we've already been through this this morning, so can benign simple descriptors be applied, i.e. step 1? Now, I'm afraid this is recorded, so just have a think about can they be applied before we nip on to the next slide. So just to recap, what are the benign simple descriptors? You can see here that they are all unilocular cysts, and they all have to be less than 10 centimeters. Now, our case is a unilocular cyst with anechoic content, smooth walls, and it had a diameter of less than 10 centimeters. Therefore, benign descriptor number 3 could apply. So thinking about the two-step strategy, when benign descriptors apply, this means this is likely to be almost certainly a benign mass, and so the recommendation is for conservative management. Now, in this case, the patient underwent surgery. Now, the main thing to think about here is that the surgery is not because there's concern that this is a potential cancer, but more because the patient presented with intermittent pain, which is the reason why we found the cyst in the first place. So in this case, we've got to think about the patient is the center of management, and the recommendation, because of the symptoms, was to undergo surgery. Now, because of her age, she underwent a bilateral selfing oophorectomy, whereas if you had a younger patient, you would then do a cystectomy as an alternative. So it's about tailoring the management to the individual patient when thinking about what the best strategy for surgery is. And as expected, the histology was a benign serous cystadenoma, which is what we thought based on the fact that we could apply to the benign simple descriptors to classify the mass. Case number 2. This was a 41-year-old premenopausal lady who was nulliparous. She was actually trying to conceive, which was why the cyst was identified. She had no symptoms and had undergone infertility investigations and had already gone through a cycle of IVF and egg retrieval. So looking at the video here, you can see that we've got an ovarian crescent. We've got possibly two cystic structures here, here and here. Let's playing that one again. We've got a unilocular cystic structure with regular cyst walls without the presence of a solid component. Now, this area here that might be your eye is drawn to was felt to be content rather than it being a solid component. The content was felt to be ground glass. And we'll flick across now to show the demonstration of vascularity. Now, remembering the colors, the way that we classify vascularity here, because there is possibly a few spots of vascularity within the ovarian stroma or the cyst wall, this could have a color score of 1 or 2. So just laying these down in terms of the specific features, this is a unilocular cystic structure, which is 23 millimeters in maximum diameter, no acoustic shadows, no solid components, and we felt it had a color score of 1, but you could argue whether it had a color score of 2. And there wasn't felt to be any ascites in this case. Again, thinking about the benign descriptors, do they apply in this case? So we've got a premenopausal lady, we've got a cyst less than 10 centimeters, and we've got a unilocular cyst with ground glass echogenicity. Therefore, we can apply benign descriptor number 1. Now, this would be typically called an endometrioma, which is not what the terminology is used in the benign descriptors here. So, applying the two-step strategy, step 1 applies. Therefore, we skip directly ahead into the management strategy, looking at the flow chart, and this is felt to be almost a certainly benign mass. Now, with that in mind, we did manage her expectantly, and this is just important to highlight that this is a patient who is looking to conceive, who we do not want to reduce her ovarian reserve. Therefore, if there is not concern regarding the characterization of the cyst or the no worrying features, then the recommendation in an asymptomatic patient should be to manage it expectantly. And the appearances of the cyst remain stable over a period of 6 months, which further reinforces the fact that it's a benign mass. So moving into slightly more tricky cases now. Case number 3 is a 34-year-old premenopausal lady who'd had one previous pregnancy, which was managed by a cesarean section, and she presented with abdominal pain following a miscarriage. Previous surgical history included an inguinal hernia. You can see here we've got the abdominal image and we've got the transvaginal image. And this is really just to demonstrate the differences, the difference you can get in terms of the perspective of a cyst by using transabdominal plus transvaginal images. You can see here that we have got a septa, an incomplete septa here, which we will see in the transabdominal that is demonstrating a complete septa, showing that this is a multilocular solid cystic structure. And if we're looking at the video here, this also just demonstrates the presence of more than one locule and the presence of a solid component here. Just running that one again. And you can see, because of the size of the mass, you're getting a slightly different perspective when you're using a transabdominal approach to scanning. It's just another video here demonstrating the presence of a multilocular solid mass. So you can see here that, again, there isn't any presence, and you probably can't see the end of the mass here to demonstrate the presence of acoustic shadows, but there wasn't felt to be any acoustic shadows in this cystic structure. So to summarize the features, this is a multilocular solid mass, and it was felt to have 2 locules with a maximum diameter of 144 millimeters, with the larger solid component measuring 73 millimeters. Although there was a solid component, there was not felt to be any papillary projections, and there was felt to have a color score of 3. Now, I'm sorry, we don't have a video demonstrating the vascularity here, and it wasn't felt to have any ascites. So thinking about applying the two-step strategy, so can we apply benign simple descriptors when we have a multilocular solid mass? Well, no, as you remember, they are only for unilocular cystic structures. And in this case, the mass is also more than 10 centimeters. So they would not be applied in this case. So we therefore move to the second step, which is the ADNEX model. Now, this is an export from the ultrasound machine, which, depending on which machine you have, will allow an export of the ADNEX score in quite a nice visual here. Now, I'm sure you recall, and we've been through these features this morning, but there are a number of features and clinical features and ultrasound features that go into ADNEX to generate a score. Now, you'll note here that we've got CA125, and it's not included in this case. So the CA125 is useful when we're thinking about, we can use the ADNEX without it, but when you add it in, you'll see in a moment, it gives you a little bit more information about the possible staging, as in not only what do we think the type of mass is, but what stage if we think it is a cancer. So you can see here that the mass is felt to be a malignant mass with a risk of malignancy of 61%. And if we add in the CA125, you can see it gives us some information about the relative risk. And in this case, the most likely diagnosis is of a stage 1 malignancy. And the risk of malignancy slightly changes with the addition of the CA125, which in this case was 33. So thinking about the two-step strategy, we've applied ADNEX, and it's given us a risk of malignancy, which is over 50%. So the recommendation would be for the patient to be managed in a specialist gynecology oncology center. Now, given her age, she underwent a fertility-sparing surgery and had a right-sided salpingoophorectomy and peritoneal biopsies. And the diagnosis was an immature teratoma, which is consistent with what we thought on the basis of the two-step strategy, that it's a malignant mass, and that the most likely diagnosis was a stage 1 mass, which is again what we've shown here. So this is very much consistent with the classification approach that we've used. Case number 4 is a 69-year-old postmenopausal lady who was a para 1, and she presented with some urinary frequency but no pain. And you can see here that we have got, flicking ahead, we've got a transvaginal approach here, and we've got the transabdominal approach. Now, you can't demonstrate all of the locules clearly within this still, but I'll show you the video in a moment. But you can see here that this is a multilocular solid cystic structure. And that's seen both transvaginally and transabdominally. And there are a number of papillary projections, which you'll be able to see a little bit better in this video. Here we can demonstrate there is a presence of internal vascularity within the solid component, and we felt this had a color score of 3. Just running this again. And you can see here the presence of papillary projections and presence of multiple locules with a solid component. So this was felt to be, as we have described, a multilocular solid mass with a maximum size of 171 millimeters and the largest solid component of 78 millimeters. It was felt to be more than 10 locules, no acoustic shadows, and more than 4 papillary projections. You can see a number of them here, but I'm afraid you don't get the full assessment of the mass just because of the size of it. And it was felt to be have a color score of 3, but no ascites. So thinking about this two-step strategy, the first step being benign simple descriptors. We've got a multilocular solid mass here. Therefore, as with the previous case, benign descriptors do not apply. And therefore, we proceed with the application of ADNEX in a two-step strategy. So again, putting in the ultrasound and the clinical variables without CA125 gives us a risk of malignancy of 79.9%. If we then add in CA125, which in this case was 906, you can see the risk of malignancy is fairly consistent with the previous without CA125, but it gives us some more information about what the type of mass this might be. And in this case, it was felt to have the most likely mass was to be a stage 1 to 4 malignant mass. So thinking about just showing visually the two-step strategy and the application of ADNEX gives us a high risk of malignancy and the recommendation to manage it in a gynecology oncology center and for surgical intervention if appropriate. Given her age and the suspected diagnosis, she underwent primary ovarian debulking, and the final histology showed a clear cell ovarian cancer with the stage 1, stage 2B even, which is again is consistent with what we felt from ADNEX. So I'm just going to pass on to Ms. Andolfo now to continue the remainder of the cases.
So we continue with other few cases. Here we have a 45-year-old lady, premenopausal, who came at our attention because of pelvic pain. This is the ultrasound of the annexal cyst. You can see how it looks like. You can see the presence of complete septa, the absence of solid component, low-level content, and you can also see some thin acoustic shadows coming from the septa. So, multilocular lesion with less than 10 locules, with the largest diameter of 11 centimeters, no solid component, there were acoustic shadows, no papillary projection. It was given a color score 2, so minimal vascularization. As I will show, there was just a few spots of vascularization in the septa, no ascites, and we had a CA125 which was available, measuring 13 kilounit per liter. So here you can see what I was saying. So just a minimal vascularization in the septa. So iota color score 2. And here you can see the contralateral ovary, which was just normal. Again, two-step strategy. First step is the application of the benign simple descriptors. Are they applicable? No. So remember, very easy. Benign simple descriptors just refer to unilocular lesions. Then, of course, there will be other features that you have to take into consideration. But as far as you have a cyst which is not unilocular, you know that you cannot apply benign simple descriptors. So first step, not applicable. We go then for the second step, the use of iota ADNEX. So we input all the different variables. 45 years old, patient was seen in an oncology center, maximal diameter of the lesion 110 millimeters. There were no solid component, so 0 millimeter for the maximal diameter of the largest solid part, no more than 10 locules, 0 papillation, yes, acoustic shadows, no ascites. Let's see what is the result of the ADNEX model without CA125 and with CA125. So, without CA125, we have a risk of malignancy of 0.7%. If we also include the value of serum CA125, which was 13, you can see that it doesn't really change a lot in terms of risk of malignancy, 0.6%. So if we go to our flowchart, step 1, benign simple descriptors, is not applicable. So we go to step 2, application of ADNEX model, which is going to always give us a risk of malignancy. In this case, it was a risk of malignancy of less than 1%, so correspond to a cyst almost certainly benign. This type of cyst could be managed in a conservative way. In this case, we remember it was a patient presenting with pelvic pain, and the cyst was anyway 11 centimeters. So again, discuss the management with the patient, and the patient preferred to have surgery, but also from our opinion, we thought that this pain could come from a cyst of 11 centimeters. So she underwent right ovarian cystectomy, and the histology was confirmed to be benign, mucinous cystadenoma, intestinal type. Next case, young patient, premenopausal, 23-year-old, presenting with symptoms, pelvic pain and irregular bleeding. Here you can see the annexal cyst, which was seen on ultrasound. You can identify the all ovary with the crescent sign, so the LT ovarian tissue around, and then the cyst clearly visible. In order to classify the cyst, we look at the presence of complete septa, presence of solid component. Here we can see one complete septa, and we can see papillations, which are by definition solid component. So it is a multilocular solid lesion. In the images, you can see just 2 papillations, but there were actually 4 in total. So multilocular solid lesion, 55 millimeter, the largest diameter of the lesion. The size of the largest solid component was 24. 2 locules, no acoustic shadows, 4 papillation, color score 2, just because of some vascularization in the septa, and no ascites. So let's see what happens with the 2-step strategy. May we apply benign simple descriptors? Again, we are talking about a multilocular solid lesion, so no benign simple descriptors applicable. We then go for the application of the IOTA Adnex model. 23-year-old lady, scanned at an oncology center, 55 millimeter, the largest diameter of the lesion, 24, the largest diameter of the solid component. No more than 10 locules, more than 3 papillation, no acoustic shadow, no ascites. And in this case, CA125 was not available. We see that the risk of malignancy was 73%, so high risk of malignancy. And in case of absence of serum CA125, anyway, if we look at the relative risk, we can see that it is higher for the borderline tumor. If we look at our flowchart, step 1, benign simple descriptors are not applicable. So then we apply step 2, Adnex model. We have a high risk of malignancy, so the indication for this patient to be treated in an oncology, gynecology-oncology referral center. And she underwent an ovarian cystectomy because of the age, and the histology confirmed a serous borderline tumor. Last case, premenopausal 33-year-old lady with intermittent pelvic pain. Here you can see the large cyst in one ovary, visible on the ultrasound. Again, presence of complete septa, no really solid components identified, low-level content. We could see also a small acoustic shadows, again, coming from a septum. Here, I will show it to you. Just here. But several locules due to these clusters of multilocular area. If we go to describe the cyst, it was a multilocular lesion, 94 millimeter in the largest diameter, no solid component, more than 10 locules, a minimal acoustic shadow, no papillary projection, we have said no solid component, just a minimal vascularization in some septa, so color score 2, no ascites, and serum CA125 was measured and was 24 kilounit per liter. Again, two-step strategy. We see first if we can apply benign simple descriptors. Again, we're talking about a multilocular lesion, so benign simple descriptors are not applicable. So this is very easy and very, very quick and fast. So we go for the application of Adnex model. We input all the different variables, 33-year-old, patient scanning in oncology center, 94 millimeter in the largest diameter, no solid component, so 0 millimeter for the large solid part, more than 10 locules, no papillary projection, presence of acoustic shadows, no ascites. Let's see the results without serum CA125, which gave a risk of malignancy of 1.8%. If we add also the value of the serum CA125, the risk of malignancy, as you can see, it does not really change, 1.9%. So still a low risk of malignancy. If we go to our flow chart, benign simple descriptors as first step are not applicable. I'm sorry. So we go for the step 2 application of ADNEX model, which gives a risk of malignancy between 1 and less than 10%. So it's a low risk of malignancy. You have, in this case, to discuss with the patient, but as low risk and not almost certainly benign, it can be discussed surgery, but this is a surgery that could be performed also in a local gynecology center. In this case, because of the size, because of the symptoms, and I have to say also the appearance of this multilocular lesion with more than 10 locules, we preferred anyway to perform surgery. Patient underwent an ovarian cystectomy, and it was actually confirmed it was a benign mucinous cystadenoma, so ADNEX was right. And this is the end of our case series.
Thank you very much for listening. We are going to be around for case discussions. So if you have any questions about any of the cases or just generally about the use of the two-step strategy, we happily answer them in the Q&A.
Thank you.
Well, Jen, Chiara, that's great. Thanks so much for your cases, some lovely cases there. I've tried to answer quite a lot of the chat, actually. A lot of this revolves around people's concerns about the availability of ADNEX, which I've explained we are solving in terms of a CE mark. You can get the ADNEX model from Evidencio, but it does require CA125, so it's not that satisfactory, or you can get it on some machines. I just want to ask you both, there's a question here about what exactly are acoustic shadows, and I was wondering if something you could both talk about, and where shadows come from. We touched on this earlier with Mila Seebar talking about the nature of acoustic shadows. I don't know, Chiara, do you have any comment on that?
Yeah, so generally, we can say that the acoustic shadows is an area, a part of the organ that we are evaluating, where the sound waves, where the ultrasound cannot propagate. So you have then a black cone behind these areas. Yep. And yeah, as you said, Prof, there can be different acoustic shadows in the sense that, for example, bones can create acoustic shadows, calcified areas can create acoustic shadows, the air in the bowel can create acoustic shadows. Sometimes it's difficult in the ultrasound images when we assess an ovarian lesion, an annexal lesion in general, to understand if these shadows is coming from the bowel, if it's coming from the lesion itself. And I think that the fact that the ultrasound is a dynamic examination, this can help a lot, because this is something that can indeed be assessed sometimes more in dynamic. Sometimes we have also acoustic shadows coming from areas with necrosis. And so acoustic shadows is ultrasound findings, which is more common in benign findings, in benign lesions, or anyway a sign of a benign characteristics. But unfortunately, it's not pathognomonic, because indeed it can be present also in areas of necrosis. Necrosis can be present also in malignant lesions. Some malignant lesions, like the immature teratoma, Jen has shown one case, show acoustic shadows. So just to remember, always take into consideration the ultrasound features together. So all the ultrasound features that you have without taking into account only one features, because we unfortunately have no single ultrasound feature that
Well,
can.
I mean, if you look at simple rules, it's about features. It's the presence and absence of features. So you can't, you know. So I think it's important to look at this that way. But I'm being told to wind up because I'm getting lots of. If I had an earpiece, it'd be like on telly. You know, get on with it. You've only got 19 minutes of this session, Tom. So I have to manage that. I'm just going to ask Jen one question because otherwise. You've logged in for no good reason, Jen. What is the tell me something about cutoff values, because this is something I think people don't appreciate. You know, you were talking, I guess, when you were defining malignancy of a cutoff of 10%. What do we mean by that? And actually, you know, are there circumstances where you might change the cutoff value to your advantage?
It's a really good question, and I think it depends partly on.
Of course it is.
Always good to start a question and answer there's that. So the main thing with the cutoff values is that it's the balance between false positives versus the pickup rate. So if you have a very low cutoff, then you're going to have a higher false positive rate, which in certain populations, particularly younger people, we're talking about we were discussing this recently in the context of pregnancy, you can result in quite a number of false positive cases. So if you were going to put the cutoff of say 30%, it means it's going to, you're basically going to mean that you're not going to overcall as many masses. So we tend to use a cutoff of 10% because it's the balance between pickup and not overcalling benign masses as malignant.
So it is rather strange because some people would be surprised to hear that they can have a negative test for cancer but have a 25% risk of malignancy, which you can in some situations, not with adnexs, but certainly, you know, we've seen this with RMI. I'm going to have to be really boring. I'm terribly sorry, both of you, because I know you're going to have to see patients now.
I know that's the sad thing.
So go on, sorry, Jen.
I'm just going to say that I think this is being recorded in terms of the cases being available for people to have a look at if they want to, in the context of particularly the question regarding acoustic shadows, to go back and look at the cases, because there are some videos demonstrating the specific characteristics.
Perfect. Okay, well, thanks for that. So just that's a good reminder for everyone that if you're registered, you can look at these lectures and review them for the next 6 months. So, you know, every weekend for the next 6 months, you can be looking at this ultrasound essential lectures. Jen, Chiara, thanks so much for your input today and for I know it takes a long time to get these cases together, so it's much appreciated. And we're going to end the session there, and we're going to have a short break, and we're going to be back on the hour, wherever you are in the world. That's going to be midday, 12 o'clock GMT, where we've got Thierry van den Bosch, and we're talking about all things endometrium and then oncology. And I'll see you later.